Hi, my name is Dr. Brandon Foreman, and I'll be highlighting a case in which point-of-care EEG can help make a timely diagnosis and lead to rapid treatment decisions in clinical practice. And when patients present with clinical seizures, they're among those with the highest risk for the development of recurrent non-convulsive seizures and status epilepticus, which require EEG for diagnosis. Delayed treatment reduces the chances of successful cessation of status epilepticus. And point-of-care EEG can dramatically shorten the time it takes to diagnose ongoing non-convulsive seizures and status epilepticus. Now, in this case, a 21-year-old man had experienced severe traumatic brain injury due to a motorcycle collision. During his initial hospitalization, he was found to have multifocal areas of contusion, transtentorial herniation, and multiple facial fractures. He underwent a decompressive hemicraniectomy, but subsequently had a prolonged hospital stay requiring tracheostomy, medications for severe paroxysmal sympathetic hyperactivity. He had a persistent disorder of consciousness, but was weaned from the ventilator and had been transferred to the floor. On hospital day 60, he had a witnessed focal motor seizure and a decrease in his Glasgow Coma Scale score to 6, indicating neuroworsening. Neurocritical care and neurosurgery were immediately contacted, and there was significant concern for seizures, although there was no clear clinical manifestation by the time of their evaluation. Now, EEG techs weren't available at this county hospital, so Ceribell was placed. As you can see here, a seizure burden of more than 90%, indicated by the red coloring of the seizure burden trend, was recorded almost immediately. And after urgent review and confirmation of the EEG by a neurologist, lorazepam was pulled and given. And there was a brief response. However, class 1 evidence suggests that for adults more than 40 kilos, 4 milligrams of lorazepam should be given for status epilepticus. So repeat dosing of 4 milligrams and subsequently 2 milligrams. After lorazepam successfully aborted status epilepticus, a very brief seizure could still be seen on the seizure burden trend, lasting less than 2.5 minutes, based on that 50% seizure burden that you can see. And it quickly resolved as the second-line anti-seizure medication was loaded. The patient was able to be transferred to the ICU for monitoring and mechanical ventilation. The seizure burden over the subsequent 4 hours remained 0%. Importantly, the majority of patients who develop non-convulsive status epilepticus are found to have an acute symptomatic cause. While unprovoked seizures are a manifestation of epilepsy, a provoked cause should always be ruled out in the right patient, as seizures may act as a harbinger of new or evolving brain injuries. In this case, CT imaging was able to uncover new hydrocephalus, which led to appropriate triage and treatment of a VP shunt malfunction. In sum, this case highlights the role of rapid EEG to improve patient care and management in the hospital setting. And without it, this patient may have had prolonged status epilepticus, which can be associated with significant morbidity and mortality.